So, there was this occupational health study back in 2020 looking at the clinical performance of medical professionals, and it made a rather terrifying
Oh,
comparison.
the shift work study.
Yeah, exactly. It demonstrated that a surgeon who is attempting to operate after a 24-hour shift, well, they exhibit the exact same objective cognitive impairment as someone who is legally too drunk to drive a car. I mean, the same delayed reaction times, the same degraded pattern recognition, the same loss of fine motor coordination.
Which is astounding when you actually frame it like that.
Right, because if you showed up to theater with a pint of beer in your hand, you would be struck off the register before you could even scrub in. But showing up dangerously sleep deprived, that is not just allowed in many institutional cultures. It is actively expected. It's worn as a badge of honor.
Absolutely. It's worn as a sign of dedication.
Yeah. So today we are looking directly into what I think is the most profound blind spot of the medical profession. We are taking a deep dive into the cognitive longevity of the clinician.
It is a striking contradiction, really. I mean, we are dealing with a population of highly intelligent, incredibly driven individuals who operate in a system that seemingly demands the active destruction of their most valuable asset. The culture of medicine fundamentally misunderstands what cognitive capacity actually is.
How so?
Well, there is this pervasive, unspoken assumption that the brain of a physician is a static, impermeable black box. That once you've passed your fellowship exams, your cognitive baseline is just locked in, and that it will simply carry on functioning at peak capacity through sheer force of will, regardless of the physical abuse you subject it to.
Which brings us to the core paradox, especially in fields like orthopedics. Because as a clinician, your entire professional life is governed by metrics, by calibration, and maintenance. You meticulously monitor your patient's physical parameters,
Right.
their inflammatory markers, their vascular health, their bone density.
Right. You leave nothing to chance with the patient.
Exactly. And in theater, you demand that your physical tools are flawless. I mean, you would never dream of using an uncalibrated navigation system for a complex pelvic reconstruction or a drill with a blunt bit or a contaminated surgical tray.
No, the risk management protocols wouldn't allow it.
But when it comes to the single most critical diagnostic and operational tool you possess, um, the physical organs sitting inside your own skull, there is an almost total absence of active, deliberate maintenance.
And that neglect is precisely why a clinician's career has to be completely reframed.
Right.
We really need to stop viewing clinical work as a series of acute sprints just to get through the current rota and start viewing it as a marathon of sustained cognition.
Right.
Because if you consider the immense physiological tax of daily clinical practice, I mean, you are making high-stakes, irreversible decisions under immense psychological pressure. You're required to recognize incredibly complex, subtle patterns on a radiograph under strict time constraints.
Yeah, with people talking to you and alarms going off.
Exactly, the ambient noise of a chaotic hospital environment.
Yeah.
You are constantly calibrating your clinical judgment across thousands of unique, unpredictable patient interactions whilst filtering out all that chaos. Every single one of those tasks relies entirely on a protected, biologically robust brain.
And that is the specific mission of this deep dive today. We are moving far beyond the vague, patronizing hospital wellness seminars that tell you to simply take a deep breath and do some yoga.
Or have a resilient mindset.
Yes, exactly. Instead, we are looking at the concrete, evidence-based biological and behavioral infrastructure that actually supports a high-performing medical mind. Because the goal here is not merely surviving until retirement. The goal is deliberately protecting your cognitive architecture so that your thinking at 65, when you're standing in theater or sitting in a consultation room, is not noticeably slower in ways you prefer not to name.
Right. It should be supported by the physical infrastructure required to actually leverage your decades of clinical wisdom.
Yes. So to protect the mind that does the work, we first need to understand the biological levers that dictate its survival. Because the daily choices clinicians make just to survive the week, the chronic sleep restriction, the reliance on adrenaline, the isolated stress, they don't just make you feel tired.
No, they induce actual structural biological alterations in the brain. They actively erode the asset.
So let us start by building that biological infrastructure, and we have to begin with the absolute bedrock. When we look at the data, the primacy of sleep is just undeniable, isn't it?
It's the single largest lever for cognitive preservation by a massive margin.
But we aren't going to just tell a senior registrar who has been up for 30 hours that sleep is good. We need to look at the novel science of why it is non-negotiable. Because a decade ago, the discovery of the glymphatic system completely revolutionized our understanding of what sleep actually achieves, didn't it?
It changed the entire paradigm, it really did. Because for a long time, the medical consensus viewed sleep largely as a state of passive rest. Simply turning the machine down to idle to save power. But the discovery of the glymphatic system revealed that sleep is an intensely active, aggressively mechanical, biological process.
Mechanical in what way?
Well, throughout your waking hours, particularly during intense cognitive exertion, like navigating a difficult revision arthroplasty or managing a deteriorating trauma patient, your neurons are firing relentlessly, and this intense metabolic activity generates toxic byproducts, most notably proteins like amyloid beta and tau.
And these are the exact same proteins implicated in long-term neurodegenerative diseases, right?
Yes, they are the primary biomarkers for Alzheimer's and other forms of dementia. So during your waking hours, these toxins accumulate in the interstitial space between your brain cells. Now, the brain doesn't have a conventional lymphatic system to clear this waste.
Right.
Instead, when you enter deep, slow-wave sleep, something remarkable happens. The glial cells in your brain actually shrink in size by up to 60%.
Wow, 60%. That's a massive physical change.
It is massive, and this massive reduction opens up the interstitial spaces, allowing cerebrospinal fluid to rush through the neural tissue. It literally washes these accumulated metabolic toxins out of the brain and into the circulatory system to be eliminated by the liver.
So if we pull this back to a clinical reality, skipping sleep is not just being tired. To use an analogy, we would never allow a scrub nurse to use a tray of surgical instruments on a Monday, leave them covered in biological debris, and then hand them back to you to use on a Tuesday.
No, obviously not.
Right. We have stringent, non-negotiable sterilization protocols. Yet, by chronically restricting your sleep to 4 or 5 hours a night, you are effectively operating with a dirty brain. You are running a highly demanding, busy clinical practice using neural pathways that are literally clogged with the metabolic debris of the previous day's work.
The surgical tree analogy is entirely apt because the debris physically impedes the function of the tools. When those metabolic toxins aren't cleared, they disrupt synaptic communication.
It slows everything down.
Exactly. Furthermore, deep sleep is the exclusive window during which complex memory consolidation occurs. It's when the brain transfers the short-term learning of the day.
Yeah.
A new surgical technique, a subtle presentation of a rare pathology into long-term structural memory.
So if you cut that short.
If you shortchange that process, the learning simply doesn't solidify. You're doing the hard work of experiencing the clinical event, but you're denying your brain the biological mechanism required to actually retain the lesson.
And the terrifying part of this biological reality is the loss of self-awareness. I mean, there is this pervasive myth of the iron surgeon who claims they only need 4 hours of sleep and operate perfectly fine. But the data shows that sleep-deprived clinicians completely lose the ability to accurately self-assess their own cognitive deficit.
This is perhaps the most dangerous aspect of chronic sleep restriction. The cognitive mechanisms required to objectively evaluate your own performance, the prefrontal cortex's capacity for self-reflection and critical judgment. Those are the very first mechanisms to go offline when you are fatigued.
It's a neurological blind spot.
Precisely. You might genuinely feel, subjectively, that you are operating at 90% capacity. You feel fine. But if we put you through a psychomotor vigilance task, objective measurements of your reaction time, your pattern recognition, and your emotional regulation would show you are operating at a severe, dangerous deficit.
It's basically the Dunning-Kruger effect of fatigue. You are too tired to realize how tired you actually are.
And this creates a vicious cycle. Because you feel fine, you continue to push the boundaries, accumulating more metabolic waste, further degrading your baseline, and permanently altering the brain's architecture over decades.
But that overnight cerebrospinal fluid flushing system we just talked about, it doesn't work in a vacuum, does it? It relies entirely on the literal plumbing of the brain, the microvasculature. Which brings us directly to the second structural pillar, cardiovascular health and the systemic brain-body link. And I suppose the fundamental rule here is that what serves the heart serves the brain.
Yes. The brain is an incredibly greedy organ. It accounts for roughly 2% of your body weight, yet it demands 20% of your total blood flow and a massive proportion of your oxygen and glucose just to maintain baseline function.
It's a huge supply chain.
And that supply chain is entirely dependent on the integrity of your systemic vascular system. If your systemic plumbing is compromised by poor cardiovascular fitness, the microvasculature in the brain, the tiny delicate vessels that feed the individual neurons, is directly and immediately impaired.
Now, I want to push back on this point on behalf of the listener because whenever the medical community talks about cardiovascular health, there is an immediate collective groan.
I know, I hear it all the time.
Right. The assumption is always that to protect your heart and brain, you need to find the time to become an elite triathlete or spend 2 hours on a rowing machine every single morning before an 80-hour clinical rota. It feels insurmountable, so most clinicians simply do nothing. They adopt a weekend warrior mentality at best.
That all-or-nothing mentality is a significant barrier, and the physiology tells a very different, much more encouraging story. You do not need to be an Ironman. In fact, extreme endurance training comes with its own systemic inflammatory costs.
Really, so what is the actual requirement?
The evidence consistently demonstrates that regular, moderate cardiovascular stimulus, specifically zone 2 training, where you are elevating your heart rate but can still maintain a conversation, that is the primary driver for preserving cerebral blood flow.
We are talking about angiogenesis and neurotrophic factors here, aren't we?
Precisely. When you engage in consistent, moderate cardiovascular exercise, you stimulate the release of brain-derived neurotrophic factor, or BDNF. This acts essentially as a high-grade fertilizer for the brain. It promotes the survival of existing neurons and encourages the growth of new synapses.
And what about the vessels themselves?
Well, more importantly for our vascular discussion, regular cardiovascular shear stress on the blood vessel walls promotes the release of nitric oxide, which maintains the elasticity and responsiveness of the endothelial lining. It's the consistency of the stimulus, 30 to 40 minutes, a few times a week, that keeps the microvasculature supple and ensures that oxygen and glucose can actually reach the neural tissue when you are 4 hours into a difficult operation.
Okay, so we have the sleep mechanism physically taking out the metabolic rubbish, and the cardiovascular system ensuring the supply lines remain robust. Let's transition to a pillar that initially sounds a bit soft, a bit less clinical, but the data shows it is incredibly potent, the nuance of social connection.
This one often surprises people in medicine.
Yeah, because we know from vast epidemiological studies that isolation is severely cognitively costly. But for a clinician, this sounds confusing. A surgeon might spend 60 to 70 hours a week surrounded by people. They are shoulder to shoulder with registrars, scrub nurses, anesthetists, and patients. Why does that constant proximity not count as protective social connection?
Because the brain categorizes professional proximity very differently from genuine human connection. This is a crucial distinction that clinicians frequently fail to make. Spending 12 hours in theater communicating effectively with your team is a professional transaction. Even when it involves camaraderie, it is fundamentally tied to your clinical identity, hierarchical structures, and continuous problem solving.
But what about trauma bonding? You finish a brutal night shift in A&E, the entire trauma team is exhausted, and you sit in the break room at 3 in the morning drinking lukewarm coffee and complaining about hospital administration or a disastrous case. It feels like bonding.
It feels like bonding, but biologically, it is simply a shared rumination on stress. When you are trauma bonding over clinical chaos, you are keeping your autonomic nervous system firmly locked in a sympathetic fight-or-flight state. You are still the doctor. True social connection, substantive, vulnerable human interaction outside of the clinical environment engages entirely different neural pathways.
Explain the mechanism behind that. How does talking to a friend who's an architect or a teacher actually protect my brain cells?
It comes down to the regulation of neurotoxic stress. When you are constantly operating in a high-stakes clinical environment, your baseline cortisol levels are chronically elevated. Cortisol is highly corrosive to neural tissue over time. When it stays elevated, it literally prunes the dendrites of the hippocampus, the brain's primary memory center.
That is a staggering visual. The stress of the job is physically dissolving the memory architecture.
It is. But genuine social connection acts as a profound biochemical buffer. When you engage in interactions where you do not have to perform, where your clinical title is irrelevant, and where no one is asking you to make a life or death decision, it activates the parasympathetic nervous system.
The rest and digest state.
Exactly. It lowers your circulating cortisol and triggers the release of oxytocin, which actively repairs the damage caused by stress hormones. You need relationships that demand absolutely nothing of your clinical executive function. That is what provides the physiological safety signal the brain requires to begin cellular repair.
Which means your identity cannot be singularly wrapped up in being an orthopedic surgeon. You have to exist as a human being outside the hospital walls, otherwise your nervous system never actually clocks off. This flows naturally into the concept of neuroplasticity through novelty. The principle is that the brain must continuously learn to remain structurally flexible. But again, a clinician might argue, well, I read the latest journals every week. I attend conferences. I am constantly learning new classification systems for fractures. Surely my brain is getting a massive workout.
That is a very common misconception. We have to differentiate between crystallized intelligence and fluid intelligence. Your accumulated medical knowledge, the protocols you memorize, the surgical techniques you refine, that is crystallized intelligence.
So it's knowledge you already have a framework for.
Right. When you read another paper on joint replacement techniques, you are certainly gaining valuable professional knowledge, but biologically you are merely reinforcing existing, deeply grooved neural pathways. It's highly efficient, but it doesn't challenge the brain's architecture.
It's the cognitive equivalent of doing nothing but bicep curls your entire life. You might develop incredibly strong biceps, but your full body mobility will be atrocious because you're only moving in one familiar plane.
That is a brilliant way to conceptualize it. To stimulate true neuroplasticity, the literal generation of new neural networks and the preservation of cognitive flexibility, the stimulus must possess absolute novelty. It has to force the brain to recruit completely dormant regions and forge brand new synaptic connections. This is the concept of building cognitive reserve.
So we are talking about forcing the brain into a state of incompetence.
Exactly. When you attempt to learn a new language or pick up a musical instrument or master a complex physical craft like woodworking, something completely divorced from the algorithms of medicine, you are forcing the brain to struggle.
And that struggle is the point.
Yes, that initial friction, the intense effort required to overcome incompetence in a foreign domain, is the exact biological trigger that builds resilience against the natural pruning of synapses that occurs with aging.
It builds a denser neural forest, essentially, so that when the inevitable cognitive decline of age begins to chop down a few trees, you have plenty of alternative pathways to rely on.
That's exactly how cognitive reserve functions.
Okay, and supporting this entire infrastructure of sleep, vascular health, connection, and novelty is the baseline fuel: stress recovery and diet. We touched on cortisol, but let's be explicit about the dietary baseline. If the brain is this high-performance machine, what does the evidence actually say about the fuel it requires?
The neurological data firmly supports a Mediterranean-style eating pattern, and not as a weight loss tool, but as a cognitive preservation strategy. The brain's cellular membranes are composed primarily of lipids. Therefore, a diet rich in high-quality omega-3 fatty acids is essential for maintaining the structural integrity of the neurons themselves. Furthermore, we must consider neurotransmitter synthesis.
The chemicals that allow the neurons to actually communicate?
Yes. Serotonin, dopamine, acetylcholine, these are synthesized from amino acids derived from dietary protein. If you are surviving on ultra-processed hospital cafeteria food, which is typically highly inflammatory and nutrient-poor, you are simultaneously driving up systemic inflammation, which degrades the microvasculature we discussed, and starving the brain of the raw materials it needs to manufacture neurotransmitters.
It is like trying to run a high-performance sports car on contaminated low-octane fuel and being surprised when the engine knocks.
It's a guaranteed way to stall the engine over time.
Right, let us consolidate where we are. We have established the precise biological inputs required to maintain the cognitive infrastructure. You need the glymphatic clearance of deep sleep. You need the sheer vascular force of regular zone 2 cardio. You need the cortisol buffering power of non-medical social connection. You need the structural resilience built by novel learning. And you need the physical building blocks of a nutrient-dense diet.
Those are the non-negotiable pillars.
But now we must confront an incredibly uncomfortable reality. The standard operating procedures of a modern medical career are practically engineered to systematically dismantle every single one of these pillars.
It is a profound structural conflict. The environment in which clinicians operate actively penalizes the behaviors required for cognitive longevity.
Which brings us to the silent erosions. We know what builds the mind, so now we need to examine what actually degrades it. Let's start with the most glaring, historically entrenched issue in medical culture: the delusion of adaptation to sleep loss. We touched on this, but we really need to look at the history here, because the modern medical residency system, with its brutal hours, was largely designed by William Halsted at Johns Hopkins over a century ago.
And it is vital to note the historical context of Halsted's endurance.
Exactly. Halsted was notoriously functioning on a massive secret cocaine addiction. He literally artificially stimulated his nervous system to withstand the punishing hours he mandated. Yet modern clinicians are expected to maintain that exact same same punishing schedule using nothing but black coffee and sheer willpower. There's a deep cultural bravado where a clinician will proudly state, my body just doesn't need 8 hours. I've adapted to 4 hours a night.
We must dismantle this myth with absolute biological certainty. Clinicians do not biologically adapt to chronic sleep deprivation. It is a physiological impossibility. You cannot adapt to a lack of metabolic clearance any more than a car can adapt to never having its oil changed.
So what is actually happening when they claim they feel fine?
They are simply experiencing a state of continuous physiological hyperarousal. Their nervous system is bathed in adrenaline and cortisol, masking the extreme fatigue. They become numb to their own degradation.
But the performance drop is still there.
Oh, the objective performance drop is staggering. If you place a chronically sleep-deprived surgeon in a simulator, you will observe an increase in microsleeps, fractions of a second where the brain literally shuts down, a severe narrowing of peripheral awareness, and a drastic reduction in the ability to pivot when a complication arises.
It's cognitive tunnel vision.
And the most terrifying aspect is the accumulation. A single all-nighter is an acute stressor, but decades of averaging 5 hours a night leads to a permanent loss of processing speed. The bravado is not demonstrating toughness, it is actively accelerating the destruction of the precise cognitive asset they are so proud of.
Compounding that sleep loss is the toxicity of unresolved stress and massive cognitive overload. We need to dissect the difference between acute stress, which a surgeon actually needs, and chronic stress, which destroys them.
The acute stress response is a beautiful, highly evolved biological mechanism. If you are the orthopedic consultant on call and a patient is rushed into A&E with a catastrophic open femur fracture, your sympathetic nervous system instantly dumps adrenaline into your bloodstream. Your pupils dilate, your heart rate spikes to push oxygen to your brain, your reaction times accelerate, and your focus narrows entirely to the massive hemorrhage in front of you. That acute stress makes you a better, faster, more precise clinician in that specific moment.
It's a biological superpower designed to save lives. But there is a catch.
The catch is that this superpower is designed to be deployed for 30 minutes, maybe an hour, to escape a predator or manage a crisis. The system is designed to immediately return to baseline once the threat has passed. The toxicity arises when that acute response is never allowed to switch off. When you leave theater, but you are immediately hit by a pager, an overflowing inbox, a dispute with hospital management, and the fear of litigation. That is sustained high stress without recovery.
This is the cognitive overload. It is the failure to secure any white space between bouts of extreme mental effort.
Clinicians today are attempting to hold an immense amount of complex, high-stakes data in their working memory. Working memory is essentially the brain's RAM. It has a very strict biologically limited capacity. When you are constantly context switching between electronic health records, patient consultations, surgical planning, and junior doctor supervision, you are maxing out the RAM.
And what does that do to learning?
This relentless overload entirely prevents the brain from consolidating information. You are demanding that the network constantly process incoming data without ever giving it the downtime required to categorize, file, and store that data.
It's akin to trying to download a massive, complex software update onto your phone while simultaneously running a dozen high-demand applications, streaming a video, and navigating via GPS. The processor overheats, the battery drains exponentially, and eventually the entire system simply freezes and crashes. And over a period of years, that constant state of hyper-alertness physically degrades the hardware, right?
The chronic elevation of cortisol actually shrinks the prefrontal cortex, the area responsible for complex decision-making and emotional regulation, while simultaneously enlarging the amygdala, the brain's fear center. You physically become more reactive and less capable of nuanced thought.
Which leads us directly to how many clinicians traditionally attempt to force their overwhelmed system to reboot. We have to address the cultural permissiveness around alcohol and the hidden dangers of a sedentary clinical life. Because historically, the medical community has harbored incredibly permissive, almost celebratory norms regarding heavy drinking as a stress relief mechanism. After a brutal 70-hour week, heading to the pub and consuming significant quantities of alcohol is entirely normalized.
It is heavily normalized, and it is a coping mechanism born of desperation. Clinicians are attempting to pharmacologically force their nervous system out of that sympathetic fight-or-flight state. Alcohol is a central nervous system depressant, so it artificially induces relaxation. However, the biological reality of that choice is unforgiving.
What does the data actually show about regular alcohol consumption and cognitive longevity?
The relationship is not subtle. Alcohol, particularly in the quantities often consumed to self-medicate clinical stress, is directly neurotoxic. But its most insidious effect is on the architecture of sleep. A clinician might drink 3 pints, pass out, and sleep for 8 hours, believing they have recovered. In reality, alcohol severely disrupts the sequence of sleep cycles. It aggressively suppresses rapid eye movement, or REM sleep, and fragments the deep, slow-wave sleep required for the glymphatic clearance we discussed.
So even though they are unconscious for 8 hours, the brain's cleaning crew never actually arrives for their shift.
Precisely. The amyloid beta and the tau proteins are left to accumulate. You are attempting to treat the psychological symptom of clinical stress by actively poisoning the organ that is stressed and simultaneously disabling its only method of repair. It is a catastrophic cognitive cost over the span of a career.
And paired with that neurotoxin is the physical reality of modern medicine. When people think of surgeons, they think of athletes standing in theater for 12 hours. But the reality of a senior clinician's life is increasingly sedentary.
The hidden cost of a static clinical life is substantial. We discussed the necessity of cardiovascular exercise earlier, but continuous ambient movement throughout the day is equally vital for cerebral perfusion.
What do you mean by ambient movement, like fidgeting?
Well, we refer to it as non-exercise activity thermogenesis, or NEAT. It's the simple act of walking, standing, and moving naturally throughout the day. A surgeon might stand for 4 hours in theater, but they are locked in a rigid, static posture over a patient. Then they spend the next 6 hours sitting at a desk, staring at a screen, reviewing scans, and typing clinical notes. Prolonged static sitting reduces overall cerebral blood flow. It signals to the body that energetic resources do not need to be mobilized.
So, to be clear, dragging yourself out of bed at 5 in the morning to do a brutal 1-hour high-intensity interval session in the gym does not biologically cancel out the damage of sitting completely still for the subsequent 14 hours.
It does not. The brain expects the physical body to be in regular, varied motion. You have to engineer ambient movement into the clinical day. Taking the stairs, standing during consultations, deliberately walking the ward, just to maintain the continuous vascular tone the brain requires.
This brings us to the final and undoubtedly the most damaging silent erosion, stigma tax. This is the tragic reality of delaying or entirely avoiding treatment for conditions like depression, severe anxiety, ADHD, or chronic sleep disorders.
It's a tragedy deeply embedded within the profession's DNA. Doctors are notoriously the worst patients. There is a profound stigma associated with admitting psychological or cognitive vulnerability. Clinicians fear the professional repercussions. They fear the regulatory bodies. They fear the judgment of their peers, and they fear the loss of their clinical identity.
Yeah.
Therefore, they mask the symptoms and push through.
But what is the actual cognitive cost of that delay? Say, if a senior orthopedic consultant is suffering from untreated clinical depression, but they are still managing to drag themselves into theater and perform the operations, what is happening to their brain?
Untreated mental health conditions act as a massive parasite on cognitive performance. Clinical depression significantly impairs executive function, degrades memory retrieval, and slows processing speed. Severe chronic anxiety monopolizes the brain's working memory, constantly scanning for threats, which leaves drastically fewer cognitive resources available for actual clinical decision-making.
By trying to protect their career in the short term by hiding the struggle, they are actively destroying the machinery required to sustain their career in the long term.
It is a devastating cycle. The delay in seeking treatment is in itself a profound and often irreversible cognitive cost.
Let us pause and look at the picture we have painted here. We have listed these erosions: chronic sleep deprivation, relentless cognitive overload, neurotoxic alcohol use, sedentary screen time, and untreated mental health struggles. It's incredibly easy for a listener, a mid-career surgeon who has just come off a punishing rotation, to hear this evidence, look back at the last 15 years of your life, and assume that permanent, catastrophic damage has already been done. It's easy to fall into fatalism and think, well, my brain is already ruined. What is the point of changing now?
Which is exactly the wrong conclusion to draw.
Right, because to make intelligent strategic career decisions, we have to learn to clinically separate temporary exhaustion from permanent trajectory shifts.
This is an absolutely crucial diagnostic distinction. There is a massive fundamental difference between the short-term cognitive load of a brutal week on call and the long-term structural trajectory of your cognitive performance over decades.
Let's use an orthopedic analogy to ground this. It's the exact difference between acute delayed onset muscle soreness, the profound fatigue and micro-tearing you experience after a massive unaccustomed physical workout, and the gradual, irreversible structural onset of osteoarthritis over a 10-year period. One is a temporary load, the other is a permanent trajectory.
That is a perfect parallel. Let us characterize the acute depletion, the short-term load. This is what you feel at the end of a 70-hour week. It manifests as a noticeable subjective sluggishness. You might experience transient aphasia, where you temporarily forget the name of a colleague you've known for years. You might find yourself making small, uncharacteristic clerical errors in your operative notes, or you might realize that you need an extra 5 seconds to interpret a slightly ambiguous radiograph that you would normally process instantaneously.
It feels awful in the moment. It feels like you are losing your edge. But what is the defining diagnostic characteristic of this state?
The defining characteristic is that this state recovers entirely with rest. It's a temporary depletion of neurotransmitters and an accumulation of acute fatigue. Once you achieve 2 or 3 nights of adequate restorative sleep, step completely away from the clinical environment and allow your autonomic nervous system to reset to baseline, your cognitive function returns fully to its previous peak. It is simply acute fatigue. The hardware is sound, the battery is just empty.
Now, contrast that acute state with the long-term trajectory shifts, because this is what we are really trying to prevent.
Long-term cognitive decline is deeply insidious, precisely because it rarely announces itself with dramatic exhaustion. It cannot always be felt from the inside on a daily basis. Instead, it manifests as a subtle, creeping loss of cognitive reserve. You might notice a slightly slower processing speed year over year.
Give me a specific clinical example of what that looks like.
Well, it looks like a gradual shrinking of your professional comfort zone. A decade ago, you might have eagerly taken on a highly complex, unpredictable revision arthroplasty, relishing the intellectual challenge. Now, you find yourself actively avoiding those cases, preferring the predictable routine of primary joint replacements. You might notice a significant increase in the sheer mental effort required to learn a new robotic surgical platform or integrate a novel pharmacological protocol into your practice. You find you have a diminishing stamina for sustained, deep analytical thinking.
Right.
A complex trauma case that you could have easily hyper-focused on for 4 hours without a break in your 30s now leaves you mentally fractured and irritable after 2 hours in your 50s.
So the critical diagnostic mistake that clinicians make is confusing these two states.
Exactly. This is where highly intelligent people make disastrous errors in self-assessment. A clinician might panic because they feel utterly depleted, cognitively sluggish, and emotionally fragile after a hellish week on the rota. They catastrophize, fearing they are developing early-onset dementia or permanently losing their clinical edge. But if they actually stop, rest, and recover fully, they might find they are still on a perfectly healthy long-term trajectory. Their baseline is totally intact. They were simply temporarily crushed by the load.
But the reverse scenario is also true, and this is where the blind spot becomes genuinely dangerous.
The reverse is far more perilous. Consider a clinician who feels entirely fine today. They have endless energy, they are crushing their surgical lists, but they're consistently surviving on 5 hours of sleep. They rely on half a bottle of wine a night to artificially induce relaxation, and they maintain absolutely zero substantive social connections outside of the hospital. They might feel fine in the short term because their system is constantly flooded with cortisol and adrenaline.
They are running on fumes and stress hormones.
Precisely. They are artificially propping up their acute performance while actively steepening their long-term cognitive decline. The structural degradation, the pruning of the hippocampus, the accumulation of amyloid beta, the stiffening of the microvasculature, it is happening quietly and irreversibly in the background. By the time they actually feel the symptoms of that long-term decline, by the time they start making actual clinical errors, a massive amount of their cognitive reserve has already been permanently lost.
Recognizing these insidious long-term shifts brings us to what is arguably the single most difficult, most painful, and most strictly avoided conversation in a clinician's entire career. What exactly do you do when the cognitive capacity of the individual no longer perfectly matches the brutal, unforgiving demands of the job?
It's a profound existential crisis for a physician, and it requires an immense amount of professional honesty. To be absolutely clear, we are not discussing pathological conditions like early-onset Alzheimer's here. We are talking about normal physiological cognitive aging confronting a high-stakes environment that demands absolute perfection.
The stark reality is that the medical field completely lacks the vocabulary, the cultural framework, and the tools to handle this transition. A brilliant orthopedic surgeon does not just wake up one morning, walk into the consultant's office, and cheerfully announce they have lost a step and need to reduce their list. Because of the surgical ego and the fear of weakness, clinicians usually make decisions about their own cognitive trajectory completely alone. They operate in a vacuum of denial, terrified of the implications, and consequently, they almost always initiate the conversation years later than they should.
This failure highlights a massive flaw in the culture of medicine. The institutional expectation is unending, linear peak performance from graduation to retirement. But the biological reality dictates that while the vast majority of physicians can practice safely, effectively, and brilliantly well into their 60s and beyond, the specific parameters of how they practice often must change.
The shape of the career has to alter.
Yes, the sheer intensity of the on-call rota, the relentless grinding pace of back-to-back outpatient clinics, or the specific complexity and unpredictability of the surgical case mix may need to be strategically adjusted to match their evolving cognitive stamina. They have decades of crystallized wisdom, but their fluid processing speed is naturally altering.
The absolute tragedy is watching a brilliant, highly respected clinician violently fight this biological reality. They refuse to step back. They stubbornly hold on to the exact same crushing workload they managed when they were 35, terrified that altering their practice is an admission of defeat. Until a catastrophic clinical error, a wrong site surgery, a misdiagnosis, a disastrous complication, forces the issue out into the open.
Which is an entirely preventable tragedy if we proactively implement frameworks for recalibration.
So how do we actually do that? How does a fiercely independent senior clinician, someone who has built their entire identity and self-worth around being the smartest, most capable person in the room, actually gather objective, reliable data on their own cognitive trajectory before it escalates into a patient safety crisis?
It requires a deliberate, structured approach, actively moving away from subjective feeling and towards objective measurement. The framework begins with honest self-assessment. Now, as we established, self-assessment is inherently flawed when you are tired, but you must attempt to strike a balance between absolute denial, pretending nothing has changed since you were a registrar, and catastrophizing, assuming that struggling to recall a drug dosage once means your career is over. You have to look critically at your own stamina, your reaction to complex cases, and your emotional regulation, entirely without ego.
But because we know the brain is terrible at diagnosing its own decline, self-assessment is merely the starting point. What is the actual mechanism for truth?
The second, far more critical step is trusted peer feedback. This is incredibly difficult in a hierarchical medical system. If you are a senior consultant, your junior doctors and registrars are absolutely terrified of telling you that you are slowing down or making uncharacteristic errors. It's career suicide for them. Therefore, you have to actively and explicitly create an environment where colleagues feel entirely safe delivering uncomfortable truths.
You essentially have to build a morbidity and mortality conference for your own cognitive health.
That is a phenomenal way to conceptualize it. You must have peers, equals in your field, individuals whose clinical judgment you respect immensely and who are not intimidated by your title, who observe your work. You have to explicitly ask them to act as your cognitive spotters. You need a colleague you trust enough to listen to when they pull you aside and say, "I've noticed you seem to be struggling with the stamina required for these complex pelvic revisions lately. Perhaps it's time to reevaluate the case mix."
And the third step removes human opinion entirely.
Yes. Objective external checks. This means voluntarily pursuing formal cognitive or clinical skills assessments. Not because the General Medical Council or a hospital board has mandated it following a disastrous incident, but out of a profound, proactive professional desire to know the absolute truth about your own biological baseline. It is treating your own brain with the exact same diagnostic rigor and respect that you routinely apply to your patients' bodies.
So what does this actually mean for the arc of a medical career?
It means fundamentally understanding that altering your clinical practice is not a defeat. It is not a failure. It is a strategic, intelligent adaptation. Clinicians who proactively adjust their work, perhaps by altering their case mix, to focus on the routine procedures they have deep intuitive mastery over, stepping back from the most punishing night call schedules to protect their sleep architecture, or intentionally pacing their clinics to allow for vital cognitive recovery between patients. These are the individuals who end their careers on their own terms. They transition gracefully, maintaining their dignity, their reputation, and their legacy.
While those who stubbornly refuse to adapt.
Those who refuse to adapt, who fight the biology until the bitter end, invariably have the terms dictated to them. It usually happens in ugly, highly public, or legally fraught ways, following a complication that, with a bit of self-awareness, could have been entirely avoided.
Let us bring all of this together. We have covered a vast amount of ground today on this deep dive. The core thesis we are presenting is scientifically inescapable. Your cognitive performance is your most valuable, yet paradoxically your least protected asset. The biological inputs required to maintain it are clear. You must prioritize deep sleep to physically clear the metabolic waste of clinical decision-making. You must maintain systemic vascular health through regular, moderate movement to preserve cerebral blood flow. You must cultivate genuine, vulnerable social connection entirely outside the medical hierarchy to buffer neurotoxic cortisol. You must pursue novel, difficult learning to drive neuroplasticity and build cognitive reserve. And you must manage chronic stress whilst fueling the machine with a nutrient-dense diet. These are simple biological concepts, but they are incredibly easily abandoned under the crushing, intense pressure of a clinical rota.
And the erosions, the chronic sleep deprivation, the reliance on alcohol, the unresolved stress, the sedentary hours, these are deeply culturally normalized in medicine, but they are biologically devastating over a 40-year timeline.
I want to leave you with a final provocative thought to mull over as you head into your next shift. In modern medicine, you mandate the daily, rigorous recalibration of your physical tools. Your MRI scanners, your surgical navigation arrays, your vital sign monitors, they're all constantly checked, serviced, and meticulously calibrated by engineers to ensure absolute, unfailing precision. If a machine is even slightly out of calibration, it is taken offline immediately because patient safety is paramount. Yet we blindly, arrogantly assume that our most critical diagnostic and operational tool, the human brain, requires absolutely zero maintenance to remain perfectly calibrated across 40 years of trauma, sleepless nights, and relentless pressure.
It is an assumption that human physiology simply does not and cannot support.
The cognitive capacity you will possess at 60 is currently being forged by the boundaries you are willing to set at 40. Protect the sleep. Move the physical body. Keep the mind learning outside of medicine. If you found value in today's expert discussion on Deep Dive Ortho, please take a moment to rate and share the program with a colleague who desperately needs to hear this. It is the single best way to support our work and change the culture. Pick one input we discussed today, whether it is fiercely protecting your sleep architecture, committing to Zone 2 cardiovascular work, or initiating genuine social connection outside the hospital, and invest in it deliberately this month. The machine requires maintenance. Make sure you provide it.